The transition from a high-end maritime expedition to a global public health emergency began on the deck of the MV Hondius, a Dutch-flagged vessel that departed Ushuaia, Argentina on April 1, 2026. What was marketed as a dream voyage through the remote South Atlantic, including stops in Antarctica and South Georgia Island, shifted into a critical containment scenario as a cluster of severe respiratory illnesses emerged among the 147 passengers and crew. By early May, international health authorities confirmed that the culprit was not a common seasonal virus, but a rare and high-consequence pathogen, the Andes Hantavirus. This specific strain of Hantavirus is primarily endemic to South America and is notorious within the scientific community for being the only known variant capable of person-to-person transmission. Unlike the more common hantaviruses found in North America, which typically require direct contact with rodent excreta, the Andes virus presents a unique risk in enclosed environments where individuals live in close proximity for extended periods. As the ship moved toward the Canary Islands, the scale of the outbreak became clear, eventually involving 11 cases including 8 laboratory-confirmed infections, and resulting in a case fatality rate currently estimated at approximately 27%. Hantavirus pulmonary syndrome, or HPS, is the primary clinical concern in this outbreak. It is a severe, often fatal respiratory disease characterized by a rapid progression from non-specific flu-like symptoms to acute respiratory distress and shock. According to the World Health Organization and the Centers for Disease Control and Prevention, the illness typically begins with fever, headache, muscle aches, and gastrointestinal distress, such as nausea and abdominal pain. However, within a matter of days, the patient's condition can deteriorate as the lungs fill with fluid, leading to severe shortness of breath and a drop in blood pressure. The mortality rate for severe HPS cases has historically been reported as high as 38%. In the context of the MV Hondius, the geographic trajectory of the ship and the timing of the infections suggest that the initial exposure may have occurred on land in Argentina during the seasonal peak of hantavirus activity. Before the virus potentially found a secondary path of transmission through the ship's shared indoor spaces and environmental systems, the framing of this event as a biotrap stems from the unique architecture of cruise ships, where ventilation systems and shared dining areas facilitate prolonged exposure among a diverse international cohort. Health officials are investigating the specific mechanisms by which the virus persisted on board, with a focus on whether the pathogen was aerosolized, meaning it became suspended in the air in tiny droplets that could be inhaled by passengers in different parts of the vessel. While the general public's risk remains extremely low, the international nature of the cruise, which carried citizens from 23 different countries, including the United States, Canada, and several European nations, has triggered a massive multi-jurisdictional surveillance effort. The event has forced a re-evaluation of how maritime ventilation and rodent control protocols are managed on luxury expedition vessels operating in endemic regions. As the investigation continues, the focus remains on identifying every potential contact and understanding how a virus typically found in rural forests managed to infiltrate a modern, technologically advanced passenger ship. The core developments of the MV Hondius outbreak were characterized by a complex chain of medical evacuations and laboratory breakthroughs across several continents. The timeline of the crisis became public on May 2, 2026, when the United Kingdom notified the World Health Organization of a cluster of severe acute respiratory illness among the ship's passengers. However, the internal crisis began weeks earlier. The first recorded case involved an adult male who developed a fever and headache on April 6 while the ship was at sea. By April 11, his condition worsened into full respiratory distress, and he died on board before formal microbiological testing could be performed. A second critical development occurred on April 24, when another passenger presented to the ship's doctor with pneumonia-like symptoms. This individual was medically evacuated from Ascension Island to a specialized intensive care unit in South Africa on April 27. It was there on May 2 that polymerase chain reaction, or PCR, testing officially confirmed the presence of hantavirus, providing the first definitive evidence of the outbreak's cause. As the ship was diverted to Tenerife in the Canary Islands, the logistical complexity of the response escalated. The vessel arrived on May 10, meeting a specialized team from the U.S. Centers for Disease Control and Prevention and European health authorities. The CDC subsequently classified the event as a Level 3 emergency response, reflecting the high stakes of managing a pathogen with person-to-person potential. By May 13, the case count had risen to 11, with additional confirmed infections reported in passengers who had already been repatriated to France and Spain. This international spread necessitated the use of the National Quarantine Unit in Nebraska and biocontainment facilities in Atlanta to house 18 returning Americans. These facilities represent the highest tier of medical isolation, featuring specialized air handling systems and HEPA filtration designed to ensure that no viral particles can escape into the surrounding environment. This level of precaution underscores the uncertainty surrounding the Andes virus's ability to spread through exhaled breath or concentrated aerosols in confined quarters. A significant point of contention among experts is the role of the ship's internal infrastructure. While standard hantavirus prevention focuses on rodent control, the BMJ and other scientific bodies have suggested that the WHO must reset its approach to airborne risks in light of this outbreak. Reports indicate that the MV Hondius, like many expedition ships, relies on integrated ventilation systems that may have inadvertently distributed aerosolized viral particles, while officials emphasize that person-to-person spread of the Andes virus typically requires close, prolonged contact, such as sharing utensils or sleeping in the same cabin. The cluster of cases across different areas of the ship has raised questions about unfiltered air recirculation. At the University of Nebraska, where quarantined passengers are being monitored, officials describe the environment as a well-managed, air-handled hotel, highlighting that air quality and filtration are now the primary barriers against further transmission. Meanwhile, laboratory sequencing and metagenomics continue in South Africa and Europe to determine if the specific viral strain involved has mutated in a way that increases its stability in the air or its ease of transmission between humans. Public health guidance in the wake of the cruise ship outbreak emphasizes a combination of active surveillance, environmental decontamination, and stringent clinical protocols. For the passengers and crew who have been repatriated, the primary directive is a 45-day window of active symptom monitoring. This unusually long duration is necessary because the incubation period for hantavirus can range from a few days to as long as 6 weeks. During this time, individuals are instructed to monitor for fever, muscle aches, and any signs of respiratory difficulty. In the clinical setting, because there is no approved antiviral therapy for hantavirus, the focus is entirely on early supportive care. Data from the current outbreak and previous studies indicate that early intervention with extracorporeal membrane oxygenation, or ECMO, can significantly improve survival rates for those in the critical phase of HPS, potentially raising the chance of recovery to 80% if the treatment is started before total respiratory failure occurs. Prevention strategies on the ship and in similar environments have shifted toward heavy-duty sanitation and air quality management. Health agencies advise against dry sweeping or any cleaning methods that could stir up dust or particles, as these can aerosolize the virus. Instead, bleach-based decontamination and the use of high-efficiency particulate air, or HEPA, filters are recommended. For future travel, the University of Surrey's Global Center for Clean Air Research has pointed to this incident as a mandate for a holistic approach to maritime health, combining robust rodent control measures with advanced ventilation systems that avoid recirculating air between cabins. Travelers are urged to remain vigilant but calm, as the virus does not survive long when exposed to sunlight or standard disinfectants. The risk to the general public remains extremely low, and there is no evidence suggesting the virus has moved into the broader community beyond those with direct links to the MV Hondius. Honest limits of current knowledge persist as researchers look for the source of the initial contamination. It remains unknown whether a rodent was present on the ship or if the first patient brought the virus on board after being exposed on land in Argentina. Furthermore, while the Andes virus is confirmed to spread between people, The exact threshold of close contact required is still being debated. Until these variables are clarified, global health agencies will continue to apply airborne precautions for any aerosol-generating medical procedures involving suspected cases. This outbreak serves as a reminder of the unexpected ways zoonotic diseases can travel through modern global transport networks. Authorities advise anyone who has recently traveled in the South Atlantic or who was on a similar expedition to report any respiratory symptoms to their healthcare provider immediately, specifically mentioning their travel history. For more updates on this and other international health reports, please consider subscribing to our channel. The core developments of the MV Hondius outbreak began with a series of medical escalations that spanned 3 continents, revealing the logistical challenges of managing a high-consequence pathogen at sea. The timeline of clinical events establishes that the crisis was underway weeks before international notification. The index case, an adult male, first reported symptoms on April 6, shortly after the vessel departed from the South Atlantic islands. His rapid decline and subsequent death on April 11th, while the ship was in transit, meant that the initial incident went without laboratory confirmation for nearly 20 days. The situation shifted from a localized medical event to an international emergency following the evacuation of a second passenger on April 27. This individual was offloaded at Ascension Island and transported via a specialized long-range medical flight to an intensive care unit in South Africa. It was there, on May 2nd, that technicians using polymerase chain reaction testing confirmed the presence of the Andes strain of Hantavirus. This laboratory breakthrough triggered a formal notification to the World Health Organization by the United Kingdom, as the vessel was operating under a Dutch flag, but carried a heavy contingent of British and European nationals, following the South African laboratory confirmation. The United States Centers for Disease Control and Prevention escalated its involvement, declaring a Level 3 emergency response. This designation allowed for the mobilization of specialized resources, including the deployment of a GO team to intercept the vessel as it was diverted to Tenerife in the Canary Islands. Upon the ship's arrival on May 10, a multinational team of epidemiologists and environmental health officers began the process of contact tracing and environmental sampling. By May 13, the case count had officially risen to 11, including 8 laboratory-confirmed infections. These cases were not confined to the vessel. Confirmed infections were reported in passengers who had already returned to France and Spain, indicating that the window for containment had already been breached. The data gathered during this phase showed a startling case fatality rate of 27%, a figure that remains under constant revision as more passengers are monitored across 23 different countries of origin. A critical point of investigative focus involves the ship's internal infrastructure, which has been described by some analysts as a biological trap. While standard hantavirus protocols emphasize the role of rodent reservoirs, specifically the long-tailed pygmy rice rat endemic to the region, the pattern of infection on the MV Hondius has led to a scientific debate regarding the ship's ventilation. The British Medical Journal, or BMJ, has publicly stated that the World Health Organization may need to reset its understanding of airborne transmission for the Andes virus. Investigators are examining the possibility that the virus, potentially introduced by an early infected passenger or a localized rodent presence, was aerosolized and distributed through the vessel's shared air handling systems. This theory of unfiltered air recirculation is supported by the fact that infections occurred in individuals who had no direct contact with the index patient or known rodent sightings. This development has forced a scrutiny of maritime engineering, specifically how luxury expedition ships manage indoor air quality in extreme environments where windows cannot be opened. The management of the 18 American citizens involved in the cruise highlights the intensity of the biocontainment effort. Upon their return to the United States, these individuals were not released to their homes, but were instead diverted to the National Quarantine Unit in Nebraska and specialized facilities in Atlanta. Officials at the University of Nebraska have characterized these units as well-managed air-handled hotels, where the air is filtered and pressurized to prevent any potential viral escape. This level of extreme precaution is tied to the unique nature of the Andes hantavirus, as the only hantavirus strain documented to move from person to person. While the passengers remain under 24-hour observation, laboratories in the United States and Europe are performing advanced metagenomics and viral sequencing. These tests are designed to determine if the specific strain involved in the MV Hondius outbreak has undergone any genetic mutations that might explain its apparent efficiency in spreading through the ship's confined quarters. As the investigation enters its second month, the focus remains on reconciling the claims of the cruise line regarding its sanitation protocols with the verified reality of an 11-person infection cluster. Public health guidance following the MV Hondius outbreak focuses on a dual strategy of long-term surveillance and environmental remediation, acknowledging the significant gaps in our understanding of the Andes hantavirus. For the 147 passengers and crew, the primary directive is a mandatory 45-day period of active symptom monitoring. This duration is significantly longer than typical viral observation windows because the incubation period for hantavirus can range from a few days to as long as 6 weeks. Health authorities emphasize that anyone who was on the vessel or who has recently traveled to the rural regions of Argentina and Chile where the virus is endemic must watch for a specific progression of symptoms. This typically begins with prodromal signs including high fever, headache, and intense muscle aches, particularly in the large muscle groups of the thighs, hips, and back. Practical guidance for these individuals includes immediate reporting of any gastrointestinal distress or the sudden onset of shortness of breath, which marks the transition to the critical cardiopulmonary stage of the disease. Clinically, the takeaways for medical providers are stark, as there is currently no FDA-approved antiviral treatment or vaccine specifically for hantavirus pulmonary syndrome. The survival of infected patients hinges almost entirely on early identification and aggressive supportive care. Data from the current cluster suggests that if a patient is moved to an intensive care unit before their blood pressure collapses or their lungs fill with fluid, the use of extracorporeal membrane oxygenation or ECMO can be life-saving. This technology, which essentially acts as an external heart and lung machine to oxygenate the blood while the patient's own organs recover, has been shown to improve survival rates to approximately 80% in specialized centers. Outside of these high-tier facilities, the fatality rate remains dangerously high, as seen in the 27% mortality rate recorded during this shipboard event. For the general public, the most practical takeaway is the avoidance of dry sweeping or vacuuming in areas where rodents may have been present. Standard prevention involves saturating potentially contaminated surfaces with a 10% bleach solution or a similar disinfectant to deactivate the virus before it can be stirred into the air. The surveillance effort currently spans 23 countries, representing one of the most complex contact tracing operations in recent maritime history. Beyond the immediate victims, the University of Surrey's Global Center for Clean Air Research and other international bodies are calling for a holistic reset of how luxury expedition vessels operate. The ethical close of this reporting centers on the responsibility of travel operators to implement stringent screening and filtration protocols when moving between endemic hotspots and international ports. There is a lingering uncertainty regarding the exact source of the outbreak. Investigators have yet to confirm if a rodent reservoir was physically present on the ship or if the virus was introduced by a single human carrier who then infected others via the ship's recirculated air. This missing link remains a critical limit of current knowledge, leaving experts to debate whether the Andes virus's person-to-person potential is higher than previously estimated. As we look forward, the MV Hondius incident serves as a case study in the intersection of luxury tourism and high-consequence zoonotic diseases. While the risk to the average person who was not on this voyage remains extremely low, the event underscores the necessity of robust global health surveillance and the vulnerability of closed-loop environments like cruise ships. Public health officials maintain a stance of calm vigilance, noting that while the virus is lethal, it is not particularly hardy outside the host and can be neutralized with standard hygiene practices. The ethical imperative for the coming months will be a transparent review of maritime health standards to ensure that shared ventilation systems are equipped with medical-grade HEPA filtration, preventing these dream voyages from becoming accidental biotraps. For continued reporting on emerging public health crises and international surveillance updates, please consider subscribing to our channel.